pleasure to announce for the continuation of the Indian-Egyptian online orthopedic course. Tonight we have two eminent speakers from India, Dr. John Mukhopadhyay, one of the eminent stars of orthopedic surgery in India, and from Egypt, Professor Mohamed Fadel, also one of the administrative board of the Egyptian Orthopaedic Association, and he's my professor, my mentor, my dear friend. Thank you so much, both of us, for joining us. First of all, I would like to thank my dear friend, Dr. Srinivas, for his great effort as the moderator of the Indian section of this webinar. Also, many thanks to OrthoTV for live streaming this webinar, and to Eva Pharma Company for sponsoring this webinar. First of all, we would like to introduce Professor John Mukhopadhyay, and Dr. Srinivas will be the moderator of the first section. Please, sir.
Thank you very much, sir. Good evening, everybody.
Good evening.
As always, I would like to thank Professor El-ashhab, the Egyptian Orthopaedic Association, Indian Orthopaedic Association, and OrthoTV. I'm very pleased today to introduce our special speaker, Dr. John Mukhopadhyay. He is one of seniors for me, actually. He was accepted. Thank you, sir, for accepting the invite to give us a talk here and share your experience and knowledge. He comes from Patna in Bihar, and he is the director and head of Department of Orthopedics and Traumatology at Paras HMRI Hospital. He is the chairman of Orthopedic Research and Education Foundation India, which is very active and has conducted numerous educational events and talks. He is a member of Regional Education Training Team, AWO Trauma Asia Pacific, and Pediatric Fracture Expert Group, AWO Trauma International, and member AWO Trauma Upper Extremity Global Expert Committee. His faculty at various national and international courses and meetings in India and abroad. Authored textbook chapters on clubfoot and distal humerus fractures and various publications in indexed journals. In the past, he has been president of Bihar Orthopedic Association. He's been education chairman for AWO Trauma India and council member AWO Trauma India, member of Pediatric Fracture Expert Group, AWO Trauma India, and chairman of Indian Orthopaedic Association Trauma Committee. Thank you very much, sir, for accepting to talk today. Over to you, sir.
Thank you very much, Srinivas, and it's a pleasure. I would like to thank the Egyptian Orthopedic Society for this invitation, as well as the Indian Orthopaedic Association, and especially you, Srinivas. And I was asked to talk on lower limb fractures, so I felt that if we just talk about lower limb fractures as a whole, it would be a bit too much. So I've decided to concentrate on fractures around the knee, that is the distal femur fractures and proximal tibial fractures. So I'll start with the distal femur fractures first. Is that showing up all right? Okay, yes, great, sir. Thanks. So the aims and objectives of this talk will be to understand the anatomy and the mechanisms of injury in fractures of the distal femur, to learn how to assess these fractures and understand the management principles. So the distal femur consists of a variable zone. About 3 to 5 centimeters of the distal femur would be included in this. This is essentially the metaphyseal and epiphyseal region of the bone. It constitutes about 6% of all fractures and 31% of femoral fractures. And as in many other fractures, has a bimodal distribution where you have young patients with high energy trauma, while the elderly often have low energy trauma, which results in fractures because of their osteoporotic bone. Now, there are certain anatomical considerations one has to keep in mind. One is that the femoral shaft is lined with the anterior half of the condyle. So it's the anterior half of the condyle which is lined with the femoral shaft, and the distal femur is trapezoidal in shape. And this has a particular relevance to how you place your plates as well as your screws. Okay, so you need to avoid going into the notch, and remember that the anterior part is not as broad as the posterior part. So you may get fooled into thinking that your screws are within the bone. As example, you can see in this patient where if you see the x-rays, you cannot tell if the screws are outside the bone. But in the CT, very clearly, the screws are crossing the opposite cortex and sticking out. So this will cause problems to the patient. You need to understand the muscle forces. There's shortening caused by the quadriceps and hamstrings. There's posterior angulation by the gastrocnemius, and rotational elements if the condyles are separated. Remember also that there could be many associated injuries, from vascular lesions to nerve lesions to fractures of the patella and other bones. Remember, you can have intra-articular meniscal or injuries or osteochondral fractures. 5 to 10% of these would be open fractures, and considerable numbers of ligamentous injuries also, varying in different studies. Now, this is one area where the AOATV comprehensive classification works really well. The A types are the extra-articular fractures. The B types are partial articular fractures, where one condyle or the other is involved. And the C types are the complete articular fractures, where there's separation both of the articular surface and of the metaphysis from the diaphysis. Now, the diagnosis, you need to look at clinical features, including whether the injury is closed or open, the deformity. You always need to check the vascularity in these injuries, as well as the neurological status. Look out for compartment syndrome, although not as common as in tibial fractures, it can happen. And also rule out any other trauma of any other bones on that limb, as well as the rest of the body. So your standard x-rays would be your AP and lateral x-rays. These intra-articular fractures, it's useful to get oblique fractures, oblique x-rays. Although today with CT scans, it's less and less required in most situations. Stress radiography may have certain indications. Remember, your x-ray should include the joint above and below, and always get an x-ray of the pelvis with both hips. Because otherwise you will miss fractures which could be there in addition to the distal femur fracture. The oblique x-rays can sometimes show up fractures, like if you see the AP and lateral, there's no obvious intra-articular injury. But if you look carefully at the lateral, at the oblique, you can see a articular step-off, and that is confirmed at x-ray. You can see the intra-articular fracture in the joint at surgery. Of course, CT scans will today give you many more details than any x-rays can give you. It can give you all the intra-articular extensions, the step-offs, the joint congruity, any other fractures which you might miss, including in the proximal tibia, because usually the CT scan will include the proximal tibia as well. And Nock et al. In their study showed that there's almost a 38% prevalence of coronal plane fractures with the high energy distal femur fractures. The lateral condyle was more often involved, which we also see in our own practice, but often these coronal plane fractures are associated with open fractures. Now, once we look at the management of these fractures, it's interesting that till the 60s, it was conservative treatment that really ruled the roost, with papers from Stewart and Minya showing excellent results with conservative treatment. However, in the 70s, we started seeing a change in scenario, especially with the advent of the AO and various papers by Wenzel et al. And Schatzker, which then showed much better results with operative treatment and early mobilization of the knee joint with operative treatment of these fractures. And as we come on to the 90s, we started seeing some of the problems with extensive soft tissue dissections involved in the methods of fixation earlier, and the more biological fixation methods came into vogue, and then the angle stable implants started getting to be much more favored for these fracture fixations. So the fixation methods before the advent of the lock plates were the angle blade plates and the DCS, which are the 95-degree plates, which worked very well. You had also the condylar plates, which were shaped a bit like the distal femur locking plates today, but without the locking ability. The retrograde IM nail became quite popular in the late 80s for fixation of these fractures, especially with the problems that we had with conventional plates. And of course, external fixators were always around. But by the 90s and at the turn of the century, it is really the anatomical lock plates which became most favored, especially for the management of intra-articular distal femur fractures. And the buzzwords in their treatment became indirect reduction, biological fixation, percutaneous or submuscular plating, and MIPO or minimally invasive plate osteosynthesis. However, remember that this indirect reduction and biological fixation pertain to the metaphysis and the diaphysis and not to the articular surface. Okay, so here is how we did some of these minimally invasive techniques before the advent of the lock plates. For example, this lady with a comminuted distal femur fracture. Here we've used a DCS, bridging the fractured area, so we're not touching the fracture area. We have an incision proximally, distally, and one stab incisions for screws in the middle. And again, you can see how the entire fracture area has been bridged without any opening of that area, and this goes on to heal quite well with good function. And so, as I mentioned, indirect reduction does not refer to the articular surface. Accurate reduction and compression are necessary for restoration of hyaline cartilage and prevention of a degenerative joint disease. So this is important still for articular fractures. And to do this, you must be able to visualize the joint surface adequately and provide stable fixation to be able to start early range of motion. So for example, a fracture such as this, where you have intra-articular and extra-articular elements, you have to visualize the joint, get the articular surface nicely reduced. This patient also had patellar fractures, and then you go on to bridge the diaphyseal area, which you can slide a plate in the submuscular plane, which is also extra-periosteal. So the surgical technique is open reduction of the articular surface with good stable fixation, closed reduction of the metaphyseal component of the fracture, submuscular placement of the LIS or distal femur LCP, and percutaneous proximal screw fixation. Okay, so what are important things in the surgical treatment is one is positioning, what approach you do, how you reduce it, and the implants you use. And I'm going to go through some of these. Remember the deforming forces, especially the gastrocnemius. So if you keep the limb straight, there will always be a tendency for the distal femur fragment to go into extension. So you need to make sure your bump is placed at the fracture level and not at the knee joint level to keep the fracture fragments aligned in the sagittal plane. It also helps to get your X-rays across. So you are able to screen, you need to have a radiolucent support for the hip. Make sure you've checked your images before the scrubbing so that you can get a good clear image. Support the other leg, and usually you need radiolucent props so that these bumps, etc., do not get in the way of your X-rays. Now, depending on whether it's an intra-articular fracture or an extra-articular fracture, for the minimally invasive plate osteosynthesis, you can do either a lateral incision for the extra-articular fracture or a parapatellar incision for the intra-articular fracture where you want to visualize the articular surface. What about the B-type fractures? Again, for the larger fragments, it's usually the anterior parapatellar approach, either medial or lateral, depending on which condyle is involved. For the really small fragments, you sometimes have to go posteriorly. For example, in this patient with a really tiny distal femur posterior condyle fracture, we went posteriorly to fix it from back to front. There's a approach where you do a osteotomy of the Gerdy's tubercle for a lateral posterior hoffa, which will give you much better access to the posterior part of the condyle. than the standard arthrotomy or anterior arthrotomy that we do. Okay, so this you can use for the lateral posterior coronal plane fractures. What is important for these coronal plane fractures is you get front to back screws, you may get back to front screws, but wherever there's a beak to the fracture, as you can see here, it's useful to also buttress this fracture. So you can see there's a large beak in the posterior aspect here, and even if you put 2 or 3 screws across, if you don't buttress this adequately, as we have done in this case, you can see how the buttress is actually buttressing this posteromedial corner, and this will then hold the fracture much better than if we just use screws. Now, coming to the C-type fractures, which is going to be the bulk of the talk, it's usually a lateral parapatellar approach that we use. This can be extended to a swashbuckler approach if you want, or you can combine it with a mipomedial or small subvastus medial approach if you need to put something on the medial side as well. So the arthrotomy, these slides are courtesy Dr. Tirachai. So the arthrotomy is 1 centimeter, usually lateral to the patella. You go proximally between the rectus femoris and the vastus lateralis, and then you can put in a Homans across the area, flex the knee, and then you have a very good exposure of the entire condyle, both medial and lateral. You need to extend adequately proximally with your incision to make sure that you can retract the patella adequately. So as usual, the usual strategy would be to convert the C-type fracture to an A-type fracture by getting the articular fracture reassembled. If you have Hoffers, you need to put front to back screws. If you have a just coronal plane, just sagittal plane fractures, you put screws from lateral to medial. So here's an example. Again, you can see a very comminuted fracture, again, confirmed on the CT scans with Hoffer elements to it. And here you can see again with this approach, what a good exposure you get of that entire articular surface. So you will gradually build up the articular surface and then do a submuscular plating for the diaphysis. So you can see how we can now get the articular surface reduced and slide your plate proximally, and you totally bridge this area. You don't really mess around with the soft tissue in this area, and you slide the plate over, put a long plate so that you get a good bridging fixation, and these will then go on to heal. One of the main problems with minimally invasive fixations is to get your alignment as well as your rotation right. And one way to check it is to make sure after you've done your fixation to put the limb through the full range of internal rotation and external rotation. And if you have the other side to compare it with, it's useful. And if you get that full range, then the chances are your rotation are okay. There are other methods like looking at the lesser trochanter and the fibula head and seeing the relationship as well. It's also useful to make sure that you check the alignment by using either a rod or this bogey wire, the diathermy wire, which if it passes from the center of hip to the center of the ankle, it should be passing around the center of the knee joint. So that will tell you that your alignment of the limb is reasonably okay. There are various techniques. Sometimes the hyperextension, you can use shank screw to put into the distal fragment, and then you can correct the hyperextension deformity by tilting it distally. Now, the various techniques you can use, one of the things is the distal femur nail, and this is especially good for the B-type fractures, where you can, there's no significant displacement of the articular surface. You can pass your nail here. This patient had an open fracture, so she had an initial external fixator and then conversion to a nail, which then went on to heal. For the articular fractures where you have coronal plane fractures, etc., then probably the plating is still the best method, although today with the newer nails, some of these fractures can also be managed with the nails. So again, you can see how the articular surface has been reduced adequately. The coronal plane fractures have been fixed, and then a plate has been slid in the submuscular plane to get good fixation, and this has gone on to heal well with a good function. Again, here you can see a more comminuted fracture. Again, the CT scans showing you the displacement and the comminution. And again, you can get a good articular reduction. You can see these screws fixing the Hoffa fragments, this going across from lateral to medial. And then you can see how the long plate has been passed. And you can see how with time this has gone on to heal well without bone grafting, without an additional plate. And this is him 2 years post-op showing an excellent functional result. Here's a proximal tibia and a distal femur fracture with a lot of comminution, articular disruption. Again, make sure you get the articular surface well reduced. Slide your plates both proximally for the distal femur and distally for the proximal tibia. And again, you can see excellent healing of this fracture using this technique with a good range of motion as well. This is another example. This was actually an open fracture with a gross amount of comminution and even some bone loss. And this is the fixation we achieved. And I was sure we were going to have to go and bone graft it and maybe add a medial plate. But it's interesting that when he came back at 3 months, he was already throwing callus. By 6 months, the fracture was going on to heal. And by 9 months, you can see how this fracture, even though there's extensive comminution, has gone on to heal with good motion, mainly because we've used the principles of bridging fixation without disturbing the soft tissue in the comminuted area. Now, there have been a number of papers looking at problems with reduction, with malrotation, and with alignment. And malrotation with the minimally invasive techniques has been found to be as high as 38 to 50%. This paper looking at problems with fixation with lock plates for these fractures. You can have too much valgus, the plate can be too anterior, it could be too distal, and for these you have to understand the design and read the manual of the plate carefully. For rotation, you need to check rotational alignment. For extension or valgus malalignment, you need to also correct the deforming forces. Okay, the plate positioning is important, so you know where the plate sits on the anterior part of the condyle, not onto the posterior part of the condyle, so that your screws go across to the opposite side. There are other techniques you can use to help you with reduction, including the use of the collinear clamp. You can use a hammer anteriorly very often. Once you put your plate and fix the proximal and distal part, it'll kind of go into procurvatum in the middle part, and you can just push that down with a mallet and put in your screws, and then this will go on to heal. You can use an external fixator to help you with the reduction. You can use screws, which can help you where the shaft fragment is medial. You can put a conventional screw into that fragment and pull it towards the lateral side, towards the plate, so that it sits exactly where you want to and in line with the articular surface. So these are various techniques you can use. You can also use a joystick on the medial side to correct any valgus or varus alignment. So here the patient is in valgus, the fixation position is in valgus. You put a shank screw on the medial side, and then you can tilt that and get the alignment corrected adequately so that your joint surfaces are parallel and you've got a perfect alignment to fix your fracture. So these are the various methods. Similarly, on the sort of coronal plane as well, you can correct any malalignment using this joystick to make sure that your fracture fixation is not in extension or flexion. So there have been also some evolution in the plates. So today you have these variable angle condylar plate system, so which allows you to put in screws through in different directions. So your lock screws don't only go in one direction. You have about a 30-degree play of the direction of the screws that you can put in. And similarly, the nails have also got advanced. The recent advancement from the AO has been this distal femur nail, which has multiple screw options, as well as a lateral attachment plate or washer, which allows you to put in screws through the plate as well as outside. And this greatly increases your ability to fix some of these distal femur fractures. So something like a periprosthetic fracture, the variable angle plates are very useful, where you can put in screws in different directions to avoid the implant and get a distal fixation adequately. Now, when is double plating necessary? Recently, there's been a lot of controversy about the use of double plates, and many authors have written papers saying that single plate constructs are not enough for some of these comminuted fractures. And one has to really view this with a bit of caution. Certainly, there are certain fractures where a medial plate would help. For example, a very low periprosthetic fracture, where you have the prosthesis in your way to get adequate fixation, it makes sense to put in a plate medially. And usually it would be depending on where the fracture on the medial side is, you would want to buttress it with a medial plate, as well as use a long plate on the lateral side. Some non-unions, especially with gaps, of course, when you're putting in bone graft, etc., you want that the medial cortex is also supported. Very osteoporotic bone. So if you have some of these low fractures in very osteoporotic bone, there may be a role for a medial plate, or even a nail and plate construct, which has become popular in the US recently, although we really still need to know long-term results of that. And a large medial hoffa along with a distal femur fracture. Very often you cannot get adequate fixation onto that. So these would be indications. For example, this periprosthetic fracture, you can see it goes on very low. You have a medial, posteromedial beak, and here you can see how we have buttressed the posteromedial side and put a long plate laterally to fix this adequately, and this goes on to heal. So there are many factors which can affect your treatment, including osteoporosis, the amount of comminution, the high velocity injuries, open wounds, the soft tissue injuries, major ligamentous disruptions, ipsilateral tibial condyle or tibial fractures, and these also have to be taken into account when you're planning your fixation. So in conclusion, I think these fractures, like any other fracture, need careful assessment and planning. You need to get anatomical reduction and fixation of the articular surface, use indirect reduction techniques and minimally invasive plate osteosynthesis for the metaphysis and the diaphysis. However, this should not be at the cost of malreduction in terms of alignment and rotation. Thank you.
Thank you so much, Professor John, for this very interesting and illustrative presentation. Thank you so much, sir, for joining us.
So,
there's one more.
Dr. Srinivas, we have, I think, some questions.
Okay, sure.
There's one more talk on proximal tibia, I think, sir.
Yeah, sure. Do you want me to take the questions now or go on to the next talk?
We'll do the questions at the end, sir.
Okay.
Okay, so I will just go on to the next talk, share my screen again. Proximal tibia. Okay, is that okay?
Yes, sir.
Okay. Yes, sir.
So I think the learning objectives in this for the proximal tibial fractures, I think the most important thing of this would be appreciating the soft tissue injury and planning and timing of surgery. Of course, you need to understand the fracture geometry. Again, you need to get articular reduction and good fixation. So I think the most important lesson that we've learned is that do not ignore the soft tissue injury if you want to avoid disasters such as this, where you have major wound breakdowns, ending up in exposure of your entire bone and plate and implants, and often ending up with an amputation. So the initial management is usually to provide stabilization of the fracture with monitoring of the soft tissue injury. Remembering that bony stability will give you soft tissue stability. So you have various methods. You can use a slab, a plaster of Paris slab. You can use skeletal traction. But probably in the significantly displaced fractures, the spanning fixator is the best way of dealing with this for various reasons, because it provides better stability and also allows you to do your dressings of the blisters and wounds without having to keep taking out the slab or the bandages to see that. Okay. So spanning fixation is really the method which is best suited for dealing with this. The spanning fixator also gives you a provisional reduction. So if you have a fracture, as you saw there, with the gross displacement, when you put on your spanning fixator, you get some kind of provisional reduction as well with ligamentotaxis. And then you can go on once the soft tissue has settled down to go on to do your definitive fixation so that it can heal without any problems of the wound. Remember compartment syndromes and vascular injuries. And remember the x-rays can change depending on how they've been taken. So this is a patient which was treated elsewhere, which we saw. And this was the x-ray that he came with, okay? And I'll show you the condition of his leg when he came, but you should see another x-ray. Okay, so that really tells you how this injury is a much more severe injury than what the x-ray that I showed earlier shows you. This is a completely dislocated knee. This was treated elsewhere, ended up with compartment syndrome, and we finally ended up in an amputation above the knee because by the time he came to us, the entire area was dead and infected all the way up to the knee joint and beyond. So this is a disaster which you want to avoid. Okay, remember that sometimes the bony injury may not show you the extent of the injury. And this is especially true of crush injuries where a weight has fallen on the leg and landed up there. And this young gentleman who we saw many years ago was complaining of just severe pain in his calf. And the back of the leg was tense, not the entire leg. Okay, so that was, you could see the thing. And then once we went in there, you could see that this was a deep posterior compartment syndrome, while the anterior and the lateral compartments were still okay. So we ended up decompressing it. His pain improved. He had no fractures that we had to fix. So basically, it was a compartment syndrome with just a crack of the tibial condyle. So the bony injury usually will tell you this amount of energy involved in the injury, but not always. And you need to really examine the patient clinically before making your decisions. Again, as I mentioned, CT scans are really necessary if you're planning to operate on these fractures. And ideally, the best time to do the CT is after you've applied the spanning fixator, because it gives you a much better picture of the real geometry of the fracture than when it is completely displaced. So the mantra is span, scan, and then plan your surgical fixation. Now, this is why CT scans are important. If you look at this X-ray, it looks like a fairly innocuous injury. But if you look at the CT scan, this is the CT scan of the same patient and shows you a significant depression on the lateral condyle. And this you would have missed if you hadn't done a CT and might have treated it conservatively, while you know that you have to treat this fracture operatively. So the Schatzker classification is the one that has been used for many years and is still the most commonly used classification for these fractures. And again, if you go through the various types, the type 1 is just a split of the lateral plateau without any depression. Type 2 is a split with a depression. Type 3 is an isolated depression, which is usually there in the elderly patients. Type 4 is an interesting fracture because it essentially says it's a fracture of the medial plateau, but many of these may often be dislocations. For example, the one I showed right in the beginning, which ended up in an amputation. So you really need to look carefully at vascularity, at the neurological status of these patients, look at ligamentous injuries, etc. Type 5 are bicondylar fractures where there's still some part of the articular surface with the shaft, and type 6 is bicondylar with a diaphyseal metaphyseal dissociation. So this is the Schatzker classification. One of the problems with the Schatzker classification was that it was based purely on AP X-rays, and this has been corrected recently. We'll talk about that, but it is still the most commonly used classification. So the AO has come out with its own classification. These fractures are 4, 1, The A are the extra-articular fractures, B are the partial articular fractures, and C are the complete articular fractures. Obviously, they are further subdivided based on the amount of comminution or the number of fragments. Okay, so this is the AOTA classification, which somehow has never been that popular for the proximal tibial fractures, but may have some relevance for research purposes. But what is most important today is that the concept of CT-based classification, and Kongfeng Luo from Shanghai was the first who came out with this paper on the 3D classification, dividing the proximal tibia into 3 columns, the medial, the lateral, and posterior. The posterior was then further divided into a posterolateral and a posteromedial column, and this became for many years the most commonly used classification or the most commonly used method of understanding these fractures. So recently, this is in just a few years ago, 2018, Kafuri with Schatzker revisited their classification and came out with this 3D based classification, 3D CT based classification, with the equator passing from the front of the fibula on one side to the back of the medial collateral ligament on the opposite side. So that was the equator. So more of the tibial condyle came into the anterior part of the fracture, a lesser bit came into the posterior column fractures. And this was further subdivided based on their original classification. So you could have a split depressed type of fracture involving one condyle or the other. So this is the Schatzker classification, which has now become a CT-based classification of these fractures. So how do you treat these fractures? So what about non-operative treatment? Again, till I remember as a resident, a lot of these patients we used to treat non-operatively, used to put them on traction, start early range of motion, and then put them in a cast brace, which allowed them movement, etc. However, today, I think surgical treatment is more favored. If you are planning to treat them non-operatively, you have to make sure that certain conditions are met. There should not be any significant joint step-off. There should be no axial instability. If there is severe osteoporosis, you may consider it because where you're worried about your fixation holding. There may be general and local contraindications to surgery, like major medical illnesses. And there are selected gunshot wounds where you probably can just debride the wound and not treat the fracture operatively, because if the articular surface is not significantly involved. So Schatzker's principles of articular fracture treatment showed that immobilization greater than 4 weeks ended up with residual stiffness. And if you operated on them and immobilized them, then they were even more likely to get residual stiffness. So regardless of what treatment you do, you must start mobilizing early. And as long as mobility is preserved, secondary reconstructive surgery is possible or procedures is possible. So if you're working in conditions which does not allow you to fix these fractures adequately, you're probably better off treating them non-operatively, mobilizing the knee, and then if they have a problem later, they can have a secondary reconstruction. And we do a lot of intra-articular osteotomies. Now coming to these various fracture patterns and how you deal with them. Remember the split depressed fracture, which is one of the most common type of fractures that we see of the lateral condyle, especially in the younger patient. You need to watch out for the lateral meniscus injury. Very often the lateral meniscus is torn and has gone into the fracture, and therefore it is important that you do a submeniscal arthrotomy as part of your surgical exposure, because only then you will see this meniscus there, and you can usually these are peripheral tears which you can repair adequately, and so you can see how we've got the meniscus back out of where it was initially in the fracture area and then gone on to repair it. The second thing that is important is that when you open the book of the lateral condyle, you are able to get so this is the lateral condyle, that is the fracture there. And the split part of the fracture, once we open out, we can see the depression clearly, and then we can elevate it with a area of subchondral bone. So you can see that we've elevated it with a significant amount of subchondral bone. And today, with the plates that we have, we can put in multiple screws into that area of the subchondral bone, and very often you do not need to bone graft it. The other area that has, this is not totally recent, but some years ago, about 15-20 years ago, the importance of the posteromedial condyle started getting recognized. Okay, so very often these fractures were being fixed with plates on both sides without understanding that the medial fragment was often a posteromedial fragment. This is an isolated posteromedial fragment. You can see on the CT scans, and this needs to be buttressed from the back. So you can use whatever approach. You can go in the supine position, like a figure of 4, or you can go from the posterior side. Here we've gone in the figure of 4 position. We actually had to look into the joint to get an accurate reduction of the joint. As you can see here, we put in a lag screw from front to back and then a buttress plate behind. There's a simple buttress plate to buttress it, and you can see how nicely this has now been restored with buttressing of the posteromedial fragment. If you don't do that, or if you don't, even in bicondylar fractures, we very often see double plates put on, but as you can see, the medial plate is too anterior and the posteromedial fragment has been totally missed, and this becomes a real problem to deal with once these fractures have united. So usually your double plate should be anterolateral plate on the lateral side, as well as a posteromedial plate buttressing the posteromedial condyle, as you can see here, and then you will get a good stable fixation of these fractures. Now, some of these fractures, a single lock plate may be enough, but you have to look at the fracture pattern. So depending on the fracture pattern, you can see the fracture lines in these patients, and then you have to see where the plates go. So as you can see, the ones in yellow, the plates are capturing enough of the medial condyle to be able to manage with a single plate, while in the ones in red, you can see that only 1.5 or 2 screws are going into the posteromedial fragment, and there's no way that they will be held adequately, and there's likelihood of secondary displacement, so you need to buttress it from the posteromedial side. The other thing is about the articular surface. I think those of us who are old enough will remember that we used to put in 6.5 millimeter cancellous screws to compress the articular surface. Today, it's been found that if we raft the subarticular surface with multiple screws, it is a better way to deal with it. So we get it reduced, we compress it, but then we put in multiple screws to actually serve as a raft under the articular surface. Okay, so this was before the advent of the anatomical plates. So we would do this, we would reduce it, and we'd put these multiple screws here, as you can see here, to raft the articular surface, and this would go on to heal well. Of course, today's lock plates allow you to do that because the plates itself have a rafting arrangement. So they have 4 screws in the proximal area, which are lock screws, and they give you a very good support of the articular surface. So our incidence of bone grafting in these fractures has gone down significantly in the acute situation. Now we come to the posterior elements of the fracture. You can have it in the posteromedial part or the posterolateral part. Here's a fracture which you can see. Again, the only part that is involved is the posterior part. Here we would use something like a Lobanoffer's approach to go from the back, go under the popliteus, retract the gastroc, go under the popliteus, which will give us direct access to the posterior part of the tibia and buttress this fracture from the posterior side. So here you can see it's a posterior buttress plate for a fracture which doesn't involve the anterior surface. So if you try to fix it from the anterior side, you will not be able to fix it adequately. Okay, so just like the posteromedial side, we are now seeing more and more fractures involving the posterolateral side. And there are various approaches for this. You can use the posterolateral approach without a fibular osteotomy. Here's a patient. Interestingly, he had an avulsion of the tibial spine as well as this posterolateral depression. So here we went posterolaterally, fixed that, and then went anteriorly and fixed the anterior tibial spine with a separate incision on the anteromedial aspect. And this is his follow-up going on to heal well with good functional results. Now you can also do a posterolateral approach from the medial side. Okay, so you have fractures where you have the posteromedial fracture as well as depression of the posterolateral part. So here you can see this. There's a posteromedial fracture as well as a posterolateral depressed part. So you can go from the medial side, go through the fracture and elevate the depressed area. As you can see there, you can go across almost all the way laterally. And here you can see we've used a combination of plates. We used a small raft sort of plate going across the lateral side. We buttressed the posterolateral corner of that area and then also a posteromedial plate to fix it. And you can see how beautifully this has got fixed adequately and goes on to heal well. The other really big approach for these fractures is the fibula osteotomy. And some fractures which really come out right opposite the fibula, this may still be the best approach. Although today people are doing things like osteotomy of the lateral epicondyle, which may give you close to the approach that you can get with a fibula osteotomy, but not quite as good. So here's an interesting case where you can see the posterolateral fragment is actually lying anterior. So we have to retrieve it with a small anterior arthrotomy, but then we have to fix it from the back. So this is the article by Solomon et al. Describing the fibula osteotomy. So that's how you do it. You separate out the fibula head, make sure you identify the common peroneal nerve first, isolate it, and then you separate out the muscles from the neck of the fibula, clear that out and do your osteotomy at the neck. And then you elevate the attachment of the lateral collateral ligament and the biceps femoris. And there you can see now you've got absolute good access to that area. That fragment is put in there, is fixed with a couple of screws, and then a small buttress plate is put on top of that. Now, one of the problems with the posterolateral area is that you cannot get a long plate. So you can actually combine a fibula osteotomy or the lateral approach with the anterolateral approach like the Frosch approach. Here we do it sometimes with the fibula osteotomy. As you can see, this fracture, which has got a severe displacement of the lateral part, it's got a small, also it's got a posteromedial fracture, but not so bad. But the fracture is quite big and extends quite a long way down onto this side here. You can see there. Now, it's difficult to buttress it adequately from the back because here you have the anterior tibial vessel going in through here and you don't want to damage that. So here, what we do this approach. We do a fibula osteotomy the usual way, get all the muscles off the neck of the fibula, isolate the common peroneal nerve, and this is the neck here. We do the osteotomy right there, just below the articular surface. And once you've done the osteotomy, you take up the fibular collateral ligament and the biceps attachment. And now you can see what a beautiful, you can do a submeniscal arthrotomy, and you can see how a beautiful approach you get to this area. You see this area, you can reduce it adequately. And in this patient, because we could not put a long enough buttress plate at the back, we decided to put in these two screws to fix the articular area once we had reduced it adequately. And then we could extend this wound anteriorly. You can see that. So we have a separate window anteriorly where we can put a longer plate there. And then we fix the fibula osteotomy. And you can see how well this has been fixed. We put a screw for the posteromedial fragment separately. And this has gone on to heal well with a good functional result at the end of it. And you can see it's got good alignment. We can also have today a lot of the combined ligamentous injury where there's been an avulsion of either the ACL with the bony fragments or the lateral collateral ligament or even the medial collateral ligament. Instead of waiting to do it later, we tend to try and deal with them at the same time. This is a young doctor who had presented to us. The fracture itself on the lateral side was not so bad. It also had a posteromedial element and they had an avulsion of the ACL. So here we went through the two incisions. We first put a posteromedial buttress plate, and then after we had done the fixation, we had to do this fixation of the ACL avulsion. So we use this lasso suture technique to pull out this fragment, get a suture around it and then pull it out onto the anteromedial side, and then fixed it with a screw wash and washer. So that's the fixation being done. The thing is being passed across, and then the sutures are then put into the with the suture disc technique. It's sutured onto the medial side. So now you have a good pull on the attachment of the ACL, which is then holding it in place. So you can see that that's the immediate post-op X-ray, lateral plate, posteromedial buttress, and a fixation of the ACL. And you can see how this is in the post-op doing well. And she's got a very good function, is able to squat, is able to walk adequately, no instability, and has done very well considering the type of injury. We also see some unusual injury patterns, and for anyone who hasn't seen this type of injury, it's not something you see very often. We've seen 2 in all these years, and here you can see how, if you look carefully, how it appears as if the lateral condyle is elevated, and that is a sign that this fragment has actually completely flipped over. The articular surface is on this side, the fracture surface is on the superior side, and here you need to retrieve this fracture, get it back, and fix it in place. And this is the follow-up. He's gone on to do quite well. This is about a 9-month follow-up of this patient doing quite well. What about definitive external fixation? Now, Ilizarov and the hybrid fixators have a role in some of these fractures, especially where there's a lot of soft tissue injury, and sometimes you may have to wait very long, and it may be easier to actually get a good fixation and reduction with the Ilizarov apparatus. You can use olive wires, etc., get a good fixation. You can bridge the joint initially if the fracture fragment is too high. And this is something we use from time to time where the soft tissue injury is very bad. Sometimes when patients come with compartment syndromes, etc., and they can do quite well and the results are not bad. And I'm sure Professor Fadel does a lot of these Ilizarov techniques because I've heard him speak on Ilizarov. And here's another one where there's an open fracture where we initially treated with the external fixator. The patient had to have a flap and a bone grafting done, and then we converted it to a ring fixator. And this is him in the ring fixator going on to do well and going on to heal well with a good function as well. So I think there are complications, whichever method you use. With the open techniques, you have problems of wound, you can have problems of compartment syndrome. With the Ilizarov, the malreductions are a little more common, and you can have intra-articular or extra-articular malreductions. Infections are more common with the open techniques. Malunions of the proximal tibia are common. Non-unions are not so common, but we do happen from time to time. So these are complications that you need to watch out for very carefully when you're dealing with these fractures as well. So in summary, soft tissue management is important in these proximal tibial fractures. Span, scan, and plan. Remember, you need to get the articular reduction adequately and stabilize them adequately so that they can start early range of motion exercises. Today, probably locking plates are most often used for the metadiaphyseal dissociation. And consider frames for more complex problems and span the knee where it is felt necessary. Thank you. Okay, so I'll stop sharing and take any questions. Okay, thank you very much.
Thank you, sir. Thank you so much. Dr. Srinivas, please, sir.
Thank you very much, sir. That was an excellent presentation covering most of the aspects for distal femur and proximal tibial fractures. We have 2 questions from the viewers. One, Dr. Sanjay Srivastava. Will placing artificial patella advisable after patelectomy? I think this is also
okay, so I think it's you want to avoid doing a patelectomy in any of these fractures. Today there are various techniques we can use to fix them, and some of the very comminuted fractures there are even plates designed to fix these fractures. However, if things are so bad that you end up doing a patelectomy, it's better to replace the patella later after it's united rather than try to do a patella replacement in the initial injury.
One question from Dr. Abdul Nasser Aldari. In temporary spanning of open comminuted proximal tibial fracture, what rule of anatomical reduction and what is the time to secondary fixation if not reduced appropriately?
Okay, so I think the spanning fixator buys you time and gives you some kind of provisional reduction. It will never give you a perfect reduction. So I think depending on the amount of displacement of the articular surface or the step-offs, you need to then get these reduced adequately. So whether you do this as two separate fixations, that means you do mini screw fixations or minimally invasive fixations of the articular surface, where you can look into the joint but not open it up completely and get the joint reduced and then still continue with the fixator, or you convert to a open reduction and internal fixation once the soft tissue has settled down. So essentially, you have to wait for the soft tissue to settle down completely. If it's a closed fracture, you have to wait for the blisters to heal and the skin to wrinkle. If it's an open fracture, you wait till you've covered the wound adequately with whatever flaps, etc., that you need to do, and then you can go on to your definitive fixation. The timelines are not, there are no fixed timelines. What you want to do maybe is avoid the 2nd to 5th days. That's the time when things are really swollen and tend to be most inflamed. But there are no fixed rules for that. You have to wait and look at things. Okay.
Can you give us any tips to reduce the stiffness of the knee postoperatively, especially for distal femoral fractures after plating?
Okay, so the plating, the most important thing is to get a good reduction and fixation and then start early motion. Okay, so if your reduction is good and your fixation is stable, you should not worry about starting early range of motion exercises. It helps to keep the knee initially in about 60 or 70 degrees of flexion in a bolster or something like that, so that you can get your rest of your movement early. So that I remember in the initial days in AO, they used to actually keep the knee at about 90 degrees after fixation. We probably accept about, and then start early range of motion exercises. We use CPM while they're in the hospital, but not after they go home. So they go on, and once they do the exercises at home, they usually, if you get your reduction adequately and the fixation adequately and the wound settles down, then range of motion is not a problem. The problem is if you have wound problems then or infection, then obviously that becomes a big issue.
Professor El-ashhab, please.
Please, Dr. John, do you use arthroscopically guided technique in tibial plateau fracture frequently?
Yeah. So we have not been using it, but it's something I would consider in the relatively low energy fractures, especially the pure depression fractures, because there to approach it, otherwise you end up having to, either you're doing a blind procedure or to approach it, you have to make windows somewhere. So there I would think of putting in a scope, looking at the articular surface, then punching it out from below and see that. We don't see a lot of those fractures somehow. I think we just get a selected number of patients who have major injuries coming to us rather than these relatively low energy fractures. So we don't see a lot of these low energy fractures in our practice. We see more of the severe energy fractures. So yes, those cases would be, I think you have to be careful in high energy fractures about the fluid extravasating and causing problems, but certainly for the low energy tibial fractures, I think it has a role. But I haven't used it myself, so
Thank you, sir.
So there's one more question from Dr. Sharif Farag. What is the duration of postoperative non-weight bearing, one for distal femoral fractures and for proximal tibial fractures?
So I think for the distal femur fractures, we start partial weight bearing more or less straight away. Okay, so once they fix them, wait for the wound to settle down 2 or 3 days, then we start them on partial weight bearing. With the proximal tibial fractures, we've been a little more cautious, but we are going towards starting partial weight bearing earlier and earlier. So I think earlier we used to keep them non-weight bearing for 3 to 4 weeks and then start partial weight bearing. Nowadays, if we can get good fixation, especially with the on both sides, I mean medial and lateral, we are happy with the fixation. Then we start partial weight bearing, toe touch ambulation almost straight away, going on to weight bearing as tolerated by 3 to 4 weeks. So we are getting a bit more aggressive with our mobilization, even with the proximal tibial fractures. But until recently, we were being non-weight bearing for 3 to 4 weeks. How do you do it?
There's one more question. Dr. Mohammad Salim Shah, thank you very much for the nice talk. My question regarding complex fractures of proximal tibia with ligament injury, how to deal these injuries, either 2-stage or 1-stage?
Okay, so I think, yeah, so the way we look at it is where there are bony avulsions, we tend to do it at the same time. If you have a ACL mid-substance tear, then we tend to fix the bones, then assess it, and then decide on their treatment later. Similarly, if there are significant posterolateral corner injuries, which sometimes happen with some of these, we would tend to try and repair them early. Okay, so bony avulsions usually at the primary sitting with the bony fracture fixation. With the soft tissue sort of mid-substance tears, we tend to fix the bone and deal with that later. Okay, so in a nutshell, that is what, obviously, individually we have to decide in a particular case. Okay.
How do you handle the blisters, sir? The clear fluid blisters and blood-stained blisters?
So I think we tend not to puncture blisters, etc. We just so the ones which have a lot of blisters, we tend to always put a fixator on and wait as long as it takes. Okay, so it can take up to 2 to 3 weeks before things are okay to fix. I think if you rush it, then you end up with problems. So yes, then the reduction becomes a little more difficult, but the advantage of the external fixator is that it usually gives you some amount of reduction by ligamentotaxis. If the condyles are widely splayed, then sometimes we'll put in a percutaneous screw at the same time, where if you are, when we put on the fixator, just make a small stab and fix that with screws if it's tending to go out of the condyle. But usually it's just a fixator to start with, and then go on as soon as things settle down. We wait as long as it takes, 2 weeks, 3 weeks, but usual time is between 7 to 10 days, but some of them take longer.
Thank you very much, sir.
Thanks, Srinivas. Good to see you.
Thank you.
Thank you so much, Professor John Mukhopadhyay, for this very interesting talk. And thank you so much for joining us, sir, in this very fruitful presentations. Thank you so much, sir.
Thank you very much.
Now we will move to the next section of our webinar. Our next speaker will be Professor Mohamed Fadel, Professor of Orthopedic Surgery, Minya University, and one of the eminent stars in deformity planning and open fractures. And he's also one of the administrative board of the Egyptian Orthopedic Association. Dr. Fadel, please.
Thank you so much. It is a very astonishing and actually I am so happy and honored to associate our dear friends Dr. John and Srinivas for their effort and their organization, and also for OrthoTV, their support scientifically and officially. Thanks again for Professor Mohamed El-ashhab, who gave me this chance to interact with our dear friends from India. We have many meetings before, but this day is under the umbrella of Egyptian Orthopaedic Association, our association, which is so proud of these frequent webinars with our friends and our partners in India. But unfortunately, I choose a topic which there is no Elizarov as you suspect, dear Jean. It is away too much. You may have no wire at all in this presentation. You remember our last meeting. We will bypass it as a memory in this talk. I will search for which is the key of sharing. Yes, I found it. Is it clear?
Yes, sir.
Yeah. So talking about open fracture of tibia, rules in adult and pediatric. Usually we miss pediatric. So if I talk about open fracture, I just listen for this topic and go directly for adult and Elizarov, as you suggested, Dr. John. I am Mohamed Fadel, and I keep myself by this very good presentation of my dear friend, Professor Mohamed El-ashhab, and appreciate so much his attitude in propagation and interaction with our friends in India. And I have many very nice occasions. We met with our friends in India since February 2021, the start of COVID, which gave us this valuable chance. This is one of the few benefits of COVID. So we attach it for many meetings, and I am honored to associate all these elegant international committee for frequent meeting in 2022, and even 2023. Just in February, last February, we share also another activities. So I am so happy to continue this via my friend, Professor Mohamed El-ashhab, and with you, our dear John and Srinivas. So looking for the open fractures, I would like to be concise and escape from the adult attitude to go for the child every now and then. The source, usually I search for a topic from the books to have some basic, and for upgrading it by some journals. So I will try to localize myself not as an open fracture in adult, but to have an insight in the rules of pediatrics. But both are similar in some things. We will talk it in a hurry, that management of open fracture, it is not a musculoskeletal injury only. It is a patient as a whole, and the trauma patient is only the representative of musculoskeletal injury in these conditions. Limb injuries is one of the problem. It is the commonest actually, but it is not the only problems. So also we look for the commonest and not looking for the most lethal, no, which is most important, the most lethal. The limb injury also is important, but we should put our mind in the head and the visceral. It's not our own mission only, but we should know this. Frequent use of ATLS, revive, review, and rehabilitation, resuscitation, ABCDEF, and looking for damage control surgery should be in our minds to stabilize the patient, avoid any problem, and delay definitive treatment. Because for the first starts, our management is not the limb, it is the patient himself first, then the limb. All these are similar in children and adults. Also, we are lucky that we have no other frustrated classification other than we are using it, which is that one of Gastelio-Templeman, and who had been revised many times until we have this last issue. We have some imperative treatment. We have some problems should be in mind. We should put on ourselves that in adult and in children, they are sharing that we are in need for eradication, sorting for the patient, and looking for closure early of the soft tissue, either by free or local or island or even a split thickness skin graft. Looking for the skeletal stabilization, adult and the child are searching for the same sequence, but the children have a many forgivable attitude. So these are similar in both. We will try to look for those of the child who is so young than the adult, and so simple solutions is amenable for him, and we should remind that child forgive. So looking for this case, if it is in adult, the condition is different too much. Looking for this case had been treated by such things. If I look for this, may I say that who madman who do this? But we will see that it is acceptable. There is union by simple means in a child. We look in a child on an adult. The same we have in this case, and devastating condition of a case open fracture with comminution and displacement so much had been solved by other unacceptable from the first vision, just monolateral flexor, 2 pins above, 2 pins below, and even the 2 pins below, one in tibia and one in the calcaneus, it looks for ourselves that it is not logic, but as we mentioned, is the case of a child is not that of an adult, and we can see that how much that this stability is enough to do an muscle flap in this case. So as a general notes, we can return again for our books, and we have the idea of the major books for children, and those of children such as Staley and that one of Rookwood, and put our mind in some basic science and making upgrading by some publications such as that one of Mohamed Bahandari and his team, and another orthoplastic approach to soft tissue management and trauma, also a group from UK. All these put a new updating of the problem of pediatric. Returning to our rules, we will find that open fractures in children most commonly involve the tibia, but sometimes we found it in supracondylar fractures and the fracture of the forearm. Femur sometimes appear. So classification, we are lucky that classification is still the same we are using in adult, which Gastelio, which is the same as one. The overall prognosis give a very good and better prognosis in children, especially in infant and younger children. Adolescents behave more likely in adult. So looking for so looking for the open fractures as a classification, we had been solved it, and the sequence of those the management in adult, and this involves the same sequence in adult: antibiotic use, tetanus toxoid, debridement, and immobilization. Limb salvage is usually feasible in children, better than that of adult. Open fracture in younger children can be managed less aggressively than those of the adolescent. There is some difference of those adult, which is also had been noted in soft tissue healing, is much more rapid and complete in children. Devitalized bone that is not contaminated can be left in place and will incorporate, in some cases, the periosteum will generate new bone when bone is lost. Gastello classification of the open fracture is still the mainstay in classification, and some cases of delayed union or non-union as uncommon in the children. External fixture may be left in place for prolonged period to have certain union and solid union later on. Updating our knowledge evolved for us a new term, which is orthoplastic approach to the soft tissue management and trauma. This group of UK and this topic as an orthoplastic had been a stakeholder in UK nowadays, and we are trying in our countries and similar countries to use it, although it is so difficult to be followed up. Next, to some extent, found updating which had been in GBGS, what is new in limb lengthening and the deformity correction. We can find that some issue about pediatric, that hexapod external fixator in the treatment of tibial fracture in children had been mentioned. So hexapod, this external fixator, which is so complicated, had been used simply in those European and in the States countries simply, other than others. So we are searching for the simple, but they are doing this by the other hand in the complex and very expensive apparatus. Looking for another research about El-ashhab bone transport and the fibula bone transport, they found for reconstruction of segmental bone defect reported equally effective. It's very good idea that El-ashhab bone transport and the fibula bone graft, which is complicated, we have a similar effect. It is very good and prognostic effect. The cost and the complication of uniplanar external fixture in their research found that it is similar to that of Taylor special frame, which is astonishing me, that the monolateral frame in our countries, which is cost few hundreds or few thousands, is equal to that Taylor special frame, which is equal around $5,000 could be treated as monolateral in a child, which could be solved by even 2 pins and even a cast. Returning to the Gastello classification, I try to discuss with my colleagues and my residents about some modification I did it for this classification of Gastello to make it so easier for them to support them and encourage them to use it. I used the letter C for 5 things. C, which means centimeter, C, which means cause, C, its cover, C, configuration, C, contamination. So looking for this, if increasing in centimeter, increasing in cause, increasing in cover, increasing in configuration, increasing in contamination, means to changing from grade 1 Gastello to 2 to 3 and other consequently. So we started by my modification to make it easier. 1 and less, it is a clean wound and type 1. More than 1 centimeter, it is type 2, and type 3 consists of 3, A, B, C. Looking for another modification for this. Type 1 is 1 centimeter and less. Type 2 is 2 centimeter and more. Type 3 consists of 3 subgroups, A, B, C. A means, and to be easier, adequate. A means a letter adequate. Adequate coverage following debridement and redebridement. B, I means bone exposed. It is a periosteal and soft tissue damage. But to make it less problem, I say that B is bone exposed. The third is C. C, no one says that it is meaning other than circulation and arterial problems. So this modification makes things to some extent easier. If we look for type 1, we will find that the cause is less, the cover is not damaged too much, the comminution is less, the contamination is less, and the comminution is less, and everything is less. So it's type 1. such as this. And usually type 1 is injury from inside out and clean wound, minimally soft tissue damage, no significant periosteal stripping. Types 2, laceration is more than 1 centimeter, no extensive soft tissue damage. There is a slight or moderate crushing, moderate comminution of the fracture, and moderate contamination, such as this example, where we find moderate soft tissue damage outside in mechanism, higher energy, some necrotic muscles, and some periosteal stripping. Looking for grade 3, we can find that extensive, more comminution, more coverage damage, more contamination, more comminution, more, everything is more. So we find this in grade 3. In this case, we have subtypes A, B, C. A is adequate, as we mentioned, adequate soft tissue coverage, and despite extensive laceration or high energy trauma, this subtype includes segmental or severely comminuted, and other things had been known well. For this example, type 3A, following debridement, we can find that it is a minimal and adequate for closure. So it is 3A, adequate for closure. Looking for this, after debridement, it could be closed. Type 3B means that we have the maximum C, cover, comminution, cause, contamination, contribution. This B means that bone exposed and in need for soft tissue reconstruction, and there is stripping, and there is bone massive comminution. So in these cases, high energy from outside in, extensive comminution requires local flap. So type 3C, looking for it, C means, as we see, circulation. Usually this is famous photo, high energy, increased risk of amputation, major vascular injury, and require repairing. So looking for these cases, it is not so simple, just supracondyle fracture, but it is a disastrous one. So we should put in mind that there is serious behind this supracondylar one. Looking for this in a child, we can find that it looks innocent for a child, but so serious for adult. To have a look what has happened, they found that it is amenable to be retained, which is so strange to be followed. If it is not my case to say that and support myself, but it is found in the Stahli book. This is they retained it because they found it is clean and could be retained. So it is after debridement, this if there is contamination, it will be removed, and if not contamination, they will keep it. In this case, they remove it if contaminated, but keep it if it is clean. The periosteum is marvelously compensate the defect, though it is big. So no problem in such cases also because he is a child. Looking for the other cases after debridement, it is in need for debridement so carefully, and to perform the redebridement maybe another time. And if we do good debridement, we may find healing of the bone without infection. This is a serious example for my colleagues to be in mind. This is a proximal tibial fracture, had been treated clearly and efficiently by these screws. Later on, there is loss of perfusion prohibited by the arteriogram that shown in the arterial injury. After reduction, they found this. Unrecognized vascular injuries that had been so unlucky patient and physician. This has resulted in because of late detection to tarsometatarsal amputation. So it is a bad lucky, not expected, but we should put in mind some bad events and some bad prognosis in unlucky patient or unlucky physician to have this case. Returning again to the open tibial fractures and the upgrading guidelines, I respect many literature, especially that of the review, as we all respecting them, especially those of Mohit Bahandari. I think most of us know this. Mohit is clever and have very good team doing a lot of research, especially those of reviewing literatures and evidence-based medicine task. They found that fractured tibial diaphyses represent one of the most major long bone fractures that currently confront the practicing orthopedic surgeon, and the overall incidence is estimated to be 17 to 23 fractures per 100,000 person per year, and young males is more, and it carries a highest risk of sustaining these fractures, with reported incidence of 39 fractures per 100,000 person per year in male from 10 to 19 years of age. It is a very considerable number. Unfortunately, up to 24% of all tibial diaphyseal fractures present as open injury, which is a big number, and are second only to phalanx fracture. You know that the baby or the child or every young children, those children usually put their phalanxes, put their fingers in anywhere. So it is the famous one, phalanx, following it, tibia fractures. And the most prevalent type of open fractures is that one, phalanx followed by open fracture of the tibia. Furthermore, considerable proportion of open tibia fracture associated with severe soft tissue compromise, especially type 3 gastelio. Road traffic accidents, including pedestrian and cyclists, have been implicated as a predominant causative mechanism, so they account for 43 up to 65 sample, and the sample size was too large, 12,754 and 1,233 of open fracture tibia. Looking for the open fracture tibia as introduction for them, most of the tibial fracture in children involve diaphyseal region and are treated similarly as comparable to adult, as we mentioned. In addition, these fractures are and associated soft tissue injury are classified utilizing the Gastello-Anderson, as we are lucky not to have a new classification, which is maybe sophisticated to be dealt. Most open fracture of the tibia result in high velocity or high energy injuries. The treatment of open fracture of the tibia in children have management principles of open fracture may be similar to many instances such adult. Initiation of appropriate antibiotic therapy immediately. Timely debridement and irrigation have some differences. Consideration may be given to non-operative treatment with irrigation and debridement in the emergency room, and administration of antibiotic in selected non-contaminated low energy grade 1 open fractures, although studies supporting this practice are underpowered. So in some cases they said that grade 1 open fracture you can do some or simple irrigation. They are not keen in this because it is underpowered study, but it is found that the importance of irrigation and the debridement in the irrigation with antibiotic in non-contaminated low energy grade 1 could be done in the outpatient or in the emergency room. Fracture reduction followed by stabilization with either external or internal fixation is the same as adult. Intraoperative angiography after rapid fracture stabilization, actually there is many controversy about angiography to be used as an assessment tool for open fractures, whatever it will be the condition. Open fracture or open wound treatment with loose gauze, packing or negative pressure dressing also is very good and beneficial. Staged debridement of soft tissue and bone in the operating room as needed until the wound are ready for closure or closure. The same technique may be in adult. Delayed closure application using a split 6 skin graft or dilated local or free vascular free grafts may be needed. Acute shortening when soft tissue and vascular stated allow in fracture and segment is considerable and could be managed in young and in adults the same. Cancellous bone grafting, either autologous or autograft for bone defect or delayed union after maturation of the soft tissue coverage. Bone transport or limb lengthening in patients with segmental loss after definitive soft tissue coverage achieved. So many things is similar and few are different. Are these principles in children similar to those of adults? There is some difference. We will talk about some difference in brief, similar to those in adults, but however, there is evidence that the difference exists between the pediatric and adult in some instances. The unique characteristic of the pediatric skeleton, these differences include the following: that the soft tissue and the bony injury heal more rapidly in children than in adults. So particularly the patient is, if less than 11 years, it is he has or she has a very fantastic and very rapid management process, and so we can find him healing in external fixator within 4 or 6 weeks. So also the vitalized and contaminated with this is astonishing for me, and still thinking to do this and do it carefully, and by myself I couldn't convince myself to use it, that the vitalized uncontaminated bone that can be covered with soft tissue can incorporate into the fracture callus. Actually, this is written, but I couldn't believe by myself and have no confidence to do to put which is outside to be inside again. In some cases, may be left within the wound in some cases. External fixation can be maintained when necessary, as mentioned, until fracture consolidation, with few concern about delayed union or non-union, because the child is low weight, also less movement if he had been hurted by another trauma. So it could be have a very good power to be held and have a soft tissue and bone healing within maybe 4 or 6 weeks. Retain the periosteum alone, even without bone inside it or even without muscular technique, can regenerate bone even after segmental bone loss in young children, as mentioned in that case from Staheli book. After thorough irrigation and debridement, many uncontaminated grade 1 open wounds may be closed primarily, which is different too much from adult, without any increase in risk of infection. Cast may be used, which is not amenable in adult to use it for adult, for definitive stabilization in selected stable open tibia fractures. This is a memory for Dr. John for last with our friends Tanisha and Arindam in last meeting. Operative treatment to open fractures needs some preoperative planning. This preoperative planning, when surgical stabilization is planned, is similar to this of the adult. The preoperative in children as those in adults may be exactly, as well as the open fractures in need for debridement of the devitalized tissue, copious irrigation, adequate soft tissue coverage is mandatory part or two of the operation. Treatment of the injury should be maintained and covered early as possible, and we should put in mind that word of orthoplastic and trying to do this with the use of the expert of our colleagues in the microsurgery specialist or plastic surgery. The technique is different and not different too much from those of adult. Any grade should have thorough and irrigation debridement thoroughly. We are trying that the wound, although there is evidence that infection rate is similar in injury, managed at least that 6 hours after injury, and those treated later. The patient tetanus toxoid and the prophylaxis should be in mind. The antibiotic should be in mind. The vitalized bone may be left, as we mentioned. Traumatic wound and could be dealt with in some wounds by secondary intention if there is moderate contamination. The patient with uncomplicated grade 1 open fracture could be managed by splint or cast. Pain fixation, which is very simple. Grade 1 open fracture, have this example. We mentioned it. Simply had been mentioned. It is astonishing, but it is for this a child. Grade 1 open fracture could be management that, such as closed fracture, so it is opened by using intermedullary nail and had been treated without deformity. For grade 2, it is extensive and so bad, but had been treated by monolateral external fixture. This is enough for it and resulted in a very good cases. Also a sliding trauma with a deceiving wound inside the cast had been debrided, and after this was amenable for closure. So it transformed into grade A adequate, grade 1, grade 3A adequate, and had been treated by conventional clamp of the adult one and using small shafts. And had been treated with excessive callus, although it is simple way of management by 1 chance below and 2 up, which is so simple and unpredictable to do this result in adult. This is outcome, very happy and little bit shy smile. Grade 3B open fractures, we should remind again that so young, so simple, child forgive, the same example I put it before. The same example, monolateral external fixture, 2 chance above, 1 chance in the distal part of the tibia, and 1 in the calcaneus and percutaneous pin. And over this, astonishing that we can do in this stable fixation flap. So this is a good results. Grade 3B, we can find that comminution, Soltal Harris had been treated also by monolateral external fixture, plates and screws, very good alignment and very good. I didn't like to frustrate you by these very nice and good examples. At last, I would like to say that as a conclusion, we put in mind that fracture in children, we have a so young, so simple solution is important, and the child forgive us. And at last, I would like to ask you to join us in the sequence, inshallah, in November, and may have a very nice meeting with us and with our board. Thank you for you, and I hope that I have no more time and make you late in this night. Thank you.
Thank you so much, Professor Mohamed Fadel, for this marvelous presentation. My dear friend, Dr. Fadel, thank you so much for joining us.
Thank you for you all.
First of all, I have a question from myself. You have mentioned that in case of compromised soft tissue, I can do acute shortening of the tibia. I'm correct?
Yes.
Yes. In acute shortening, do you fix with a plate or you do fix with El-ashhab and then do a gradual distraction later on after callus is formed, sir?
Very good question, and it is a complex situation in a child. The child, as we know, forgive, yes. The discrepancy, if it is few centimeter, 1 or 2, may be compensated and also have many solutions. We can do approximation, and after doing compression, we can make distraction gradually, as you mentioned, using either monolateral or El-ashhab. This is one. The second, if he is so big enough, we can do some bone substitutes with few bone grafts from cancellous bone and put this for 1 or 2 centimeters, because the child can accommodate this, and putting a plate, as you mentioned. It is very good idea. So we have many solutions. It is not important to do usually a bone transport, except we bypass 3 centimeters or 4 centimeters. In this case, I think that it is the good one is to use bone transport using El-ashhab.
Yes, sir. And in case of acute shortening, if the fibula is intact, of course, I have to do fibulectomy.
You are right. And in this case, we can use this part of the fibula to put it in this.
Yes.
You got it. You
Yes.
put it in this distance and everything is finished. Because just a few months, maybe 6 months, you will find the fibula intact, even if you take 1/3 of the fibula in
Yes.
a child.
Sir, I do the fibular graft. I
right.
put the fibula, or I do fibular transport by El-ashhab.
Very good. Very good. Excellent.
Yes, sir. Another question, sir, or it's a comment. I think the main difference between the pediatric and adults, that in pediatric, if I use the monolateral frame or the uniplanar frame, I can use it as a preliminary and a definitive way of management. But of course,
Excellent.
in adults, this is not allowed.
It is difficult, especially for monolateral, though some friends say that it is possible, but it is easy for circular frame as El-ashhab. It could be from the start to be a definitive and preliminary. But we should mention for our colleagues, residents, no time for El-ashhab at all, for the acute or for the fracture, no time at all. Don't think for El-ashhab for any, you should think in ATLS, damage control surgery,
Yes.
every minute. Just 10 minutes you can do monolateral fixture and say goodbye, and our neurosurgeon and internal surgeon, surgery and the plastic, they are working. They are in need for just in a hurry.
Yes, sir. Yes, sir. Dr. Srinivas has a question, and then we will take the questions of our attendees. Please, sir.
Welcome.
Yes, sir. Excellent presentation, sir. Thank you very much. Just a couple of questions, actually. One is, can you give guidance on the amount of irrigation fluid to irrigate open fractures in adults, and is there a difference between adults and children? And also your views on implant removals in children.
Implant removal in children. We can start by the lavage and the irrigation. It depends, as you know, and as our friends know, according to the condition and situation, we may not in need for any irrigation. In some cases, if there is a fracture or open fracture from within, for some time, for example, you may need not too much to irrigate. But for those of highly contaminated or the cause or of high energy trauma or the comminution or the contamination or any C of the C from the level of 5, high contamination, high cause, high contamination, high comminution, all these conditions in need for irrigation, you may not enough 7 liters or 10 liters. You may need more, because following washing, you make another debridement and found a new problem again. After seeking that everything is good, you make disclosure and make kinking to look behind the bone, and we may find a soft tissue behind the bone, which one of the serious things is to miss the back of the bone, because the bone after cracking, it hurts the posterior, not the anterior only. So it is open buffet for working, lavage. So I couldn't define, though there is a fixed volume as a start, but it is not defined. Looking for the implant removal, in many instances in the epiphyseal fracture, it is not important to remove, but it is a hell of question and asking of the parents to remove everything, because if it stay, he will be short, and even the limb will be shorter than the other. And this is what is not right. The discrepancy between both limbs, it is not related to the the fixed part of a diaphysis, but maybe nearby epiphyseal injuries, maybe. But for the safety of some parents who are anxious for doing this, I think it is important to quiescent them and do this. Although from the start, I think it is few cases to be internally fixed in children.
Thank you, sir. We have a question from our dear attendees, sir. First question from Dr. Sanjay. Do we still go for conservative treatment in fracture nowadays, as some prefer nailing and plating to reduce the days of morbidity and also to reduce the days of hospitalization?
I think in the children, as we talk now, it is so simple to use open fracture and internal fixation, and it is also of benefit for the physician and the hospitals, but it is not good at all for the patient. We know all that it is not good for fracture humerus or tibia to be solved by a cast. It is so simple. Though it is against even the evidence-based researches. I am against this to do, except if it is indicated.
Yes, sir. Another question from Dr. Abdel Nasser. What the Gastello grade that allows intramedullary nailing use primarily in adults and children?
Intramedullary nail in adults, as you see in this example, it could be used safely in the children, but we asking ourselves about indication. It is used safely, and generally speaking, many authors agree about that. Open fracture grade 1, 2, 3, and 3A, B, and the most of C, except for some instances, all of these could be managed not by intramedullary. This is well established since long time ago, and I couldn't say no. Yes, it is fact, and it is also a golden solution. If you have a clean wound, you can do this for all types of.
Another question from Dr. Mahmoud. For how long do you give intravenous antibiotics for type 3?
It depends upon the heavily contaminated and those in the farmyard, or also this is the clean area. But in those who are having debrided for a very frustrating wound and spend a long time in this debridement, I think this depends upon the culture that had been taken early before debridement from the start, maybe 6 biopsy to be taken before debridement. Following this, the results of culture may help me so much to do this.
Do you prefer, sir, to use antibiotics in washing or put it locally in the wound, or you don't prefer it?
Actually, using antibiotic locally, I am not with them in most instances, and it is better to be used intravenously, effective and well mentioned in many by many authors.
Dr. Srinivas, please.
So just one question for both, actually, to Dr. Fadel and Mukhopadhyay, about availability and use of hexapod frames in Egypt and India. Are there any alternatives, or they're very expensive, isn't it? So is there a way of getting them? How frequently do you use them?
So in India, there is some locally manufactured alternatives to the tailor spatial frame. So you had the SUV and now you have the hexapod, which are being made in India, which are less expensive. So they're relatively cost effective for even our patients. So I think it can be used, yeah. But it's I think it's a mindset as to people who, you have to have a slightly technical mind to be able to do those things. I'm still a traditional orthopedic surgeon. So I stick with the standard Elizarov frames, etc. But certainly for some complex deformities, they have a role. There's no doubt about that.
By myself, I am one of the earliest publishing a paper about talospatial frame in 2005 with my mentor and the professor friends, Professor Gamal Hosni, in 2003, I think, or 2004. But using talospatial frame at that time was maybe through a period of awards from the government. But following this research, though it is famous and one of the earliest publication, we didn't use after finishing of these tools because it's too expensive.
Yeah.
It maybe nowadays about 200,000 Egyptian pounds, around $10,000. It looks too much. So I was laughing and astonishing. They are talking about the comparative study between monolateral extensor sector and hexapod and fracture tibia.
Yeah,
They are talking another language. So it is a joke.
So in India, they are now making frames which are very similar to the talospatial frames being manufactured.
Yes, I know
they
them.
also provide the software which is not as expensive as it is for the talospatial frame.
Yes, they are effective and very good, but also still expensive to get it.
It's
this
still
type
expensive.
Yes, still.
It's
So
not
no
cheap.
way to use it, and it will be out of dates. And even talospatial frame especially, it will be out of dates this year because their software will be end, and even the factory will stop talospatial frame. It will have nowadays go for another type.
Mm-hmm.
Yes, I think we have no more questions. Finally, I would like to thank Professor John Mukhopadhyay, Professor Mohamed Fadel for their excellent presentations and for joining us tonight. Thank you so much, our dear professors. Many thanks to my dear friend, Dr. Srinivas Kambhampati, for being the moderator of the Indian part of this excellent course. Thanks to OrthoTV and to Eva Pharma Company. And many thanks to our dear attendees for joining us in every Friday. We see you next Friday, inshallah, with two speakers, one from India and one from Egypt, speaking about robotic total knee and navigation in total knee replacement, and hope to see you very well, inshallah. Thank you so much and have a nice time. Thank you, sir.
Thank you very much, everybody.
Thank you, sir. Good night, sir. Thank you so much.
See you. Good night.
Bye.